Hello, I'm Rachel Babin from Oncology News Australia, proud producers of the Oncology Journal Club podcast. Join Eva Segelov, Craig Underhill and Hans Prenen as they chat through the latest papers. In today's episode, Eva talks us through melanoma papers. Craig gives us his wrap-up from the 2021 San Antonio Breast Meeting, and Hans looks at cytoreductive surgery for relapsed ovarian cancer and the Codebreak 100 trial. We've plenty of quick bites and a new offering in our The Paper That Changed My Practice segment. In the amazing paper of the week, we'll look at sexual desire in female cancer survivors. You'll find links to all of the papers, bios and Twitter handles in the notes on our website. So join us for the most relaxed oncology education podcast. Reach out to us on Twitter using hashtag OJC. For regular news and podcast updates, subscribe to the Oncology newsletter on oncologynews.com.au. It's free and it's a great way to support the OJC. This is Rachel Babin and this is the Oncology podcast.
G'day. How are you, Craig Underhill?
Really great, Eva. So much better than I was last episode.
Okay. Any injuries?
No.
Personal medical stories?
I'm sort of sore in the right places because we're playing soccer at the moment. And, you want to get that delayed onset muscle soreness a couple of days after you play in the right places. And so, yeah, I wouldn't say injuries. I'm just sort of feeling a bit sore from that.
Okay, good sore. How about you, Hans?
I'm happy to hear that Craig does some sport. Really positive.
Great. Well, without further ado, we've got some great stuff to discuss. Over to you. And I must describe the computer screen. So when we record this, we record it on a platform called Squadcast. So we can actually see each other, although obviously only the sound is recorded. And you get to write your name. And so we try and be witty and write our name. So Rachel's name is Rachel, so she's not very witty. But Craig's name is Ralagalax. And if you don't know why that's funny, listen to the episode before this. And my name's Sympathy Joe Hurty because I've still got my sore finger.
Is it coming good?
And it's coming good. It's way better than last episode. And Hans has got his title head of the department at the age of 45. Woohoo! All right, Mr. Head of Department,
yes.
Hit us with your main paper.
I selected two papers, and I don't know if it was a rule in OJC that we could not present papers where we co-author, but I don't know the existence of that rule. So the first paper is in Lancet Oncology, January, it's a very recent one, with sotorasib, as you know, the KRAS G12C inhibitor, in patients that are previously treated with colorectal cancer. So this is a part of the Codebreak 100 trial, where a lot of patients are treated, also lung cancer, with KRAS G12C, but they present the data for patients with colon cancer, because a lot of people claim, okay, it's working really nice in lung, but it's not really active in colon. So that's why I wanted to present this data. So the patients,
I start crying now?
No, actually not, because the patients needed to be chemorefractory. So you have to think this is a chemorefractory group, the patients that usually receive either TAS-102 or regorafenib. And in this case, they were treated with sotorasib 960 milligrams. So this is the highest dose, because as you know, there are many doses looked at in the phase 1. There were 62 patients with colon cancer, so quite some number. And with a partial response in 10%. You could say, okay, 10% not that high, but if I ask you, okay, what is the percentage response with regorafenib? It's 0%. So I think 10% is still some good result. Also, toxicity-wise, only 10% had grade 3 toxicity, and this is mainly diarrhea, and this is manageable. So I would say it has some modest activity, but as you know, many trials are ongoing to combine it with, for example, anti-EGFR, etc., to increase efficacy. So I think there's still a role for the inhibition of KRAS G12C in colon cancer.
And we might need to use it much earlier.
Yeah, indeed. Yeah, fully agree.
Oh, Hans, can I ask you a question about your first one? So how many colon cancer patients have the KRAS mutation approximately?
It's a good question. As you know, in lung, it's quite frequent, and in colon, it's I think it's 2-3%. That so it's not that frequent.
And the 12C?
That's the 12C that I mean. So the KRAS in general is 40% for between 40-50% have KRAS, and the G12C is only 2-3%. So it's very little.
It's actually higher than 40 to 50% if you do extended RAS.
Right.
So it depends if you're talking about KRAS or including
but we speak
NRAS.
about KRAS. If you don't include NRAS, of course.
So in lung, it's 30% KRAS mutated. So that was the kind of holy grail because we didn't have a drug against that really big population, and it's 12% overall, the KRAS 12C. So it's quite a lot. You think about how common lung cancer is, and so it's really exciting. And we've got a phase 2 study and seen patients have really good responses to this drug. N equals very small, but
that's why, because it's working so good in lung cancer that people are a bit demotivated when they see the results in colon or in other tumor types, because even cholangio, pancreatic, etc. But still, there is some efficacy. So there is still, and I had one patient with colon in that trial who was good on this treatment for more than a year. So this is, I think, a good result.
Right.
Yeah, but we're used to molecular targets not working in colon, at least with single agent BRAF. Hey, but listen, I got a DM on my Twitter from the wonderful Annabelle Smith, who is a oncology fellow in Adelaide. And she actually sent this yesterday and said, just listening to OJC, and I've got to know, why is your favourite RAS mutation G13D? So I just wrote back ice cream.
Yeah.
And I think she thinks I'm crazy.
Yeah. Do you want to explain that to people?
So this is the new generation. Nah, it's a generation. Look it up. Segelov ice cream G13D.
Everybody knows the ice cream trial.
Not anymore, sadly.
Okay, but let's go to my second main paper, Eva. And you asked me last year to have something more on non-GI, so that's why I selected this time a paper from the New England ovarian cancer. And it's a randomized trial of cytoreductive surgery for relapsed ovarian cancer. And I discussed it actually with my gynecological colleagues because I'm not familiar with that. But as you know, patients that had a recurrence of ovarian cancer relapse after platinum-free interval. Sometimes they only give chemotherapy without surgery. But this study is a randomized study, and they looked whether these patients could be treated either with chemo alone or with secondary cytoreductive surgery and then platinum-based chemo. I have to highlight that they use some kind of score system calling AGO. It's some German name of this score. And it's based on ECOG, ascites, complete resection at initial surgery. So they look into some criteria, whether the patients can get surgery, yes or no. But to summarize the results, there were more than 400 patients, and the survival in the surgery group was 53 months versus 46 in the no surgery group. So I discussed with my gynecology colleagues, and they say they already do this secondary cytoreductive surgery if you have this positive AGO score. But maybe, Eva, you know more about these things as you treat gynecological tumors.
I used to. So, look, firstly, fantastic to do this trial. It is not easy to randomize someone to a surgery versus no surgery trial. Is a really hard thing. There's so many biases already. And for surgeons to participate in this I don't think we'd be able to do it in Australia. Happy to hear from listeners who disagree, but we struggle to do surgery versus no surgery in colon, in breast, lots of cancers. So congratulations. It's about whether they're picking the winners anyway. And there's not a huge difference in that. So that was median OS. Is there any other information?
No, it's mainly about a median OS.
Yeah. Again, ovarian cancer is not just one entity, molecular entity, but I think it's great that we're doing this. And there is biological plausibility as well to debulking, of course, that is starting to manifest perhaps in other cancers as well against the paradigm, although the evidence is weaker, isn't it?
But you remove actually clones that are resistant. So that's why I'm not in every tumor type, of course, but in some tumor types, it makes sense to remove the resistant clones.
Yep. And we do it for liver resection in colon cancer a lot. But was there a minimum criteria of the disease-free interval prior to relapse? Are they already picking good performers?
It had to be actually a platinum-free interval of 6 months. That was the main inclusion. Yeah.
Okay, that's pretty reasonable. Excellent. Thank you for ovarian cancer. I'm very impressed.
You going to do yours now, Eva?
I will. Okay, look, I've been on a little bit of a melanoma binge the last few. So, Craig, actually, you haven't read your letter from UNSW about how to use your title, because you are allowed to be referred to as professor.
Really?
If you're an associate professor, just in writing, it should be associate professor. That's the old rules. Have a look.
Oh.
And let us know. It might have changed.
And
all right.
When people are boarding planes and they go, welcome professor or welcome doctor, which do you think sounds more prestigious? Are you going to put professor? Do I should put professor on my Qantas?
Put professor on your Qantas.
Do you think so?
Yep. And then also when someone's sick on the plane, you can say you're a professor of mathematics.
Oh, dear. Eva, what's your...
So...
You got a melanoma. Have you got?
I'm buzzing on melanoma.
You don't have a melanoma, do you? Because you suddenly seem to be interested in melanoma.
Oh, no. I don't have a melanoma. I'm just like Hans, going outside GI. But this is the Relativity 047 trial published in New England Journal. Relatlimab and Nivo versus nivolumab in untreated advanced melanoma. So this was a BMS-funded trial. So relatlimab is a LAG-3 blocking antibody. So LAG stands for lymphocyte activation gene 3, and it's a different checkpoint inhibitor, also inhibitory, from the PD-L1 locus. So this is a cell surface receptor found on activated CD4 T cells, and it's got specific binding sites and a very high affinity for MHC class 2, and it acts to directly inhibit T cell activation. So it makes sense to add different checkpoint inhibitors together. So this is a phase 2/3 double-blind randomized trial. Very simple design. The combination is a fixed dose versus just Nivo intravenously every 4 weeks, so very reasonable scheduling. First-line therapy. Primary endpoint, however, PFS. And indeed, the median PFS was 10.1 months with a 95% CI 6.4 to 15.7, so very wide, and compared to 4.6 months, 95% CI 3.4 to 5.6. So hazard ratio for progression or death, 0.75, with a 95% CI 0.62 to 0.92. Obviously, that's going to be statistically significant. So progression-free survival at 12 months, around 48% with the combination, compared to 36% with the single. And there was significant finding of grade 3-4 treatment-related adverse events in only around 19% of patients in the combo and about 10% in the single. And this is really important because obviously this combination is going to challenge Ipi-Nivo as a new standard of care. It sounds about the same, and yes, Checkmate 067 combination Ipi-Nivo PFS 11.5 months, so remarkably similar. We don't have for this trial OS yet, but in the Nivo Ipi Checkmate 067 trial, the grade 3 or 4 treatment-related adverse events was around 60%.
So that's the big difference, isn't it?
That's the big difference. Now, there are some biomarkers to come out, and they did measure LAG3 as a biomarker, LAG3 expression, and in the patients that had expression less than 1%, that subgroup seemed not to benefit. So again, there'll be some subtleties here. Now, we should see a head-to-head trial. An accompanying editorial in the New England said we're not going to see that. They almost implied it would be unethical because of the toxicity. I'm not so sure. I think there may be other factors there, but a new combination, lower toxicity, we'll see that go forward, I'm pretty sure.
Yeah, I'm not so sure either. You would think that maybe there does need to be the randomized phase 3. I'd love to ask Georgina Long, who we've had on the show before, and I'm sure she mentioned this study when we last talked to her. A big shout out to our advanced trainee, Richard Kelly, who presented this paper yesterday in our local journal club.
Oh, what did he say?
Well, we talked about sort of similar issues to what we're talking about now, about the difference in the toxicity, whether the comparator was valid. So, yeah, interesting study, but I get the sense that this will be pushed to market pretty quickly. And, we know IPI is very expensive, right? So if the price is right, it may be something that comes to the fore. And, a lot of patients do get single agent nivolumab. They're not well enough to get ipi-nivo. So certainly for the patients who aren't suitable for ipi-nivo, this looks like it's a valid treatment option. But, the melanoma doctors love to talk about the plateaus on the curve and the 3, 4, 5 year overall survival. So we don't have that yet, and we won't have it for several years. So
that'll be critical too as
but,
well.
Do we wait or do we jump on this? And obviously in other tumours, there's going to be lots of LAG3 studies.
Let's do a head-to-head. That's what I vote. All right, fantastic. And your main paper, Craig?
Well, main papers. So,
main papers, they're taking over.
Like to make it hard for myself. So I just thought we didn't really do anything on San Antonio. So I found someone's tweet on what they thought was the best 5 papers from San Antonio. So I did a bit of research. So we'll whiz through these pretty quickly, and we'll have some links that people can click on if they would like on some information. And there'll be some commentary because unless you register for San Antonio, you can't easily get the abstract. So the first one was 21 gene assay to inform chemotherapy benefit in node-positive breast cancer. So this was published in the New England the same time as the San Antonio conference on 16th of December 2021. So it was a comparison of the premenopausal women and postmenopausal women with the 1 to 3 positive nodes and a recurrence score of 25 or lower. And it basically showed that the premenopausal women with 1 to 3 nodes, current score of 25 or less, seemed to benefit from chemoendocrine therapy as opposed to endocrine therapy alone. So that's the first one. The next one was dual checkpoint inhibition showing promise for highly mutated HER2 negative metastatic breast cancer. This is a phase 2 Nimbus study. So in this study, patients needed to have a TMB score of at least 9, so that's a reasonably high mutation rate. They were given Nivo, all right, and then final analysis of the PALLAS study showed no benefit with palbociclib plus endocrine therapy in early breast cancer. So a negative study, final analysis. Emerald phase 3 study shows improved outcomes for metastatic breast cancer patients treated with elacestrant who progressed on prior endocrine therapy. So this was interesting. This is an oral selective.
Oral SERM.
Yeah, it's a SERD. It's a oral selective.
Sorry, a SERD.
Yeah, oral selective estrogen receptor degrader. Significantly decreased disease progression, increased progression-free survival compared to standard of care endocrine therapy.
Yeah, that'll come into practice.
Yeah,
soon.
so an oral, again, another oral agent. So patients won't need to come in for fulvestrant injections. And that's about it from
That's a wrap.
San Antonio.
Fantastic. It's just the timing of San Antonio. Like, who's got time to have the highlights? It's Christmas, and then by the time you get the highlights, it's 3 months later. But that was a great wrap. So thank you very much, Craig.
Pleasure.
Excellent. And Mr. Head of Department, at the age of 45, do you have a quick bite? And make sure it's short,
Yes.
not a medium bite.
I selected 3 short bites, and I can be very quick about this. The first one is actually a review, because I was quite interested in this. It's published in Critical Reviews in Oncology Hematology, and it's about pseudo-progression in lung cancer patients treated with immunotherapy, because I'm always interested in pseudo-progression, because I would love to see it everywhere. And as soon as a patient progresses, you say it might be pseudo-progression, but in practice, you don't see it that much. But for those that don't know it, it's a transient tumor enlargement or even appearance of new lesions. And the mechanism might be associated with lymphocyte infiltration. But I was surprised to read that even pleural or pericardial effusion may suggest pseudoprogression. This is something I don't see in non-lung cancer patients. But how do you solve it then? The authors suggest that you could look at ctDNA as a potential method to identify pseudoprogression. But I advise the listeners to read this review. The second paper is about genomic profiling of neuroendocrine carcinomas. And this is also something that Eva likes. It's published in Cancer Discovery, December 2021. And actually, to summarize, they found genomic differences between pancreatic neuroendocrine carcinomas and non-pancreatic. So it may be that there are 2 completely different diseases. So we have to think maybe in the future of treating them differently. And then the third and last one that I selected is about adjuvant therapy in stage 2. For me, it's still a problem, because I see so many T3N0 and T4N0 colon cancer. I think the pathologists do it on purpose, because that's the most difficult decision to give adjuvant or not. So this paper was published in GCO, and it's the updated ASCO guideline. So I was surprised what they state. And they state that if you have a T4, you should be offered adjuvant chemo. When you have another risk factors, and you know all the risk factors with perineural lymphatic invasion, poor differentiation, obstruction, tumor budding, sampling less than 12 lymph nodes, all these things, then they state you may be offered adjuvant chemo. And then the question is adding oxali, yes or no. They say, okay, it may be offered. And with MSI without risk factors, I think we agree no chemo. MSI with risk factors, they advise oxali-based chemo. And then the question about the duration, 3 versus 6, answer, you can choose. But it's a shared decision-making, and that's what we do in practice. And I must say that I give a lot of 3 months of Xelox now, even in a stage 2, because it's quite short. You give maximum therapy, and polyneuropathy on the long term, it's not a big problem at that moment.
So why are you surprised about the T4N0? Because their prognosis is often worse than T3N1 low nodes, 1 to 3 nodes. So it's always been a fault of the staging 1, 2, 3, 4 or the old dukes. I would treat a T4N0 with a shared decision making for a small potential benefit. But the rest of stage 2, and how much each of those individual risk factors adds.
But the main problem is if you decide not to give chemo and you relapse, you always will have the question, what if? And so this makes it quite difficult. I think it's very tough to give a decision not to give adjuvant chemo.
Well, yes, maybe ctDNA will help us. That's the great hope.
Yeah. Yeah.
Beautiful. Short and sweet, just like you, Head of Department. Thanks, Hans. Love your work. Now, I've got a couple of short bites. I'll be quick because Hans always thinks I'm too slow. The first one was from BMJ 2020. It's the mortality due to cancer treatment delay, systematic review and meta-analysis. I think everyone needs to have a copy of this. 34 studies for 17 different cancer indications, all curative, neoadjuvant or adjuvant, whether they involve surgery, systemic therapy, or radiotherapy. 1.2 million patients, 20-year time span from the year 2000. And the main outcome measure was the hazard ratio for overall survival for each 4-week delay for each indication. And they defined delay from the diagnosis to the first treatment or the completion of one treatment to the start of the next. They were very fussy about the studies that they chose, had to be highly valid, controlling for major prognostic factors. They found an association between a 4-week delay and increased mortality that was significant for 13 of the 17 indications. All the surgery ones, so colectomy, breast surgery for cancer, etc. Every 4-week delay was associated with increased mortality from cancer. For systemic therapy, the estimates varied. For radiotherapy, curative radiation, again, you had this association. And they did a sensitivity analysis that showed comorbidities or functional status didn't change the findings. So this is the seminal paper to quote when you want to say that even a 4-week delay of cancer treatment is associated with increased mortality from cancer. Very prescient in current times of COVID.
I've got a C-word paper as well, Eva, for my quick bite.
Go ahead.
COVID vaccination and breakthrough infections in patients with cancer, published in the Annals of Oncology. It's an analysis of the COVID-19 and Cancer Consortium, which is an international prospective database for people with cancer and COVID. So this was done at the sort of start of the Delta outbreak, so it's pre-Omicron, basically showing there was no difference in the 30-day mortality between fully vaccinated patients compared with the unvaccinated. So the outcomes were pretty bad in both. So unvaccinated patients had a 50% chance of being hospitalised, the vaccinated 65%, unvaccinated 13% chance of going to ICU, the vaccinated the same, and the 30-day mortality was 10% in the unvaccinated, 13% in the fully vaccinated. So the conclusions were that these breakthrough infections in vaccinated patients are still significant and, can lead to very bad outcomes. So this is highly relevant to the current kind of philosophy in Australia. I think the conclusions were that measures other than vaccination, such as mitigation approaches to including vaccination of close contacts, boosters, social distancing, mask wearing in public, will need to continue for the foreseeable future.
N95s, not a cloth mask.
Yeah, so we need to
for Omicron,
and it's not just the people with cancer who need to do that. We all need to do that as a society to protect those vulnerable people.
Vulnerable people being left out, aren't they? Anyway, let's not go there. It's too upsetting. Let me go to my gender equity paper of the week.
You're serious, aren't you?
I am, every week. JAMA Network Open 2021, Women Oncologists' Perceptions and Factors Associated with Decisions to Pursue Academic versus Non-Academic Careers in Oncology, a cross-sectional survey in the US performed in 2020, 667 female respondents. Now, interestingly, 63% of them identified as an academic oncologist, and most of the respondents, whether academic or not, perceived that their gender adversely affected job promotion. And this is the really interesting and sobering point. More than 20% of respondents were considering leaving academia. So we've still got a long way to go. I've got an amazing article. So the reason I think it's amazing is there's no way this is ever going to work, but kudos to them for doing the trial. So it's a study called the Randomized Controlled Phase 2 Evaluation of 2 doses of bupropion versus placebo for sexual desire in female cancer survivors, published in JCO. So bupropion is a dopaminergic agent. And they did this trial. They measured the desire on the female sexual function index and looked at toxicity in postmenopausal women with breast or gynae cancer and low scores after they'd completed their definitive cancer therapy. 230 women and no difference. Why am I not surprised? We're not like men. Viagra won't solve our problems. I think there's more than a bit of dopamine.
But is
needed.
it like a sertraline? I would just wish everyone could see Rachel's face because there was a real eye roll during that presentation, just thinking, why did Eva pick this one? But is it is it like sertraline or?
It's a dopaminergic agent.
Right.
That's all it is. It's trying to enhance your dopamine. And, there was no multidisciplinary approach. There was no.
But isn't that the same as chocolate or getting liked on Twitter? Isn't that a dopamine hit?
So do they work for you? But look, in all seriousness, it's great to see these trials, this whole field of cancer survivorship. And, I particularly worry about, and probably worse in these times of COVID, but all this quality of life and particularly discussing sexual function, I think gets very little airtime and is very, very important. Right.
I agree.
You have another short bite.
I do, Eva. And Rachel, we've got a new segment and you might need a little sound bite here. It's this is the blow your own trumpet paper of the week because inspired by Hans presenting his own paper. I thought I'd throw in this as a quick bite. So this is the Canadian Cancer Trials Group Lung Disease and the Australasian Lung Cancer Trials Group, CCTG BR34, a randomized phase 2 trial of durvalumab and tremelimumab with or without platinum-based chemotherapy in patients with metastatic non-small cell lung cancer. So our colleague Natasha Leal in Toronto was the first author, and there's this guy called Craig Underhill from Albury who's an author on this paper. So it was looking to add standard cisplatin-based chemotherapy to durva-tremi, first-line treatment, but didn't improve survival in the analysis compared with durva plus tremi alone. This was in all PD-L1 score patients. But it was interesting, the response rate was higher, 29% versus 44%. The progression-free survival was 3.2 months versus 7.7, so doubling, which reached statistical significance. But the overall survival in this study of 300 patients was 14 months versus 16 months, and the hazard ratio was 0.88, but that crossed the 1. So p-value 0.46. So it didn't quite meet statistical significance. So again, this is a complicated field. Do we need chemo and 1 or 2 checkpoint inhibitors? Can we just give checkpoint inhibitors or dual 2 agents alone? And this study would suggest that there was an advantage to adding chemo, but not in terms of survival. But interestingly, the toxicity was higher in that combination than in the immunotherapy alone group, which is what you'd expect. So there you go.
Blow your own trumpet. Trial. I love that. Okay, let's see if we can. Now I've got a little quiz for you.
Oh no. This is putting me on the spot, Eva. It's late. Come on.
No, this is interesting. Okay, so what are the words, or I should say the suffixes tug, but, mig, and ment mean?
I saw something about this. This is some change in the system of antibody classifications. Is that right?
Oh, well done. Yes. So the group in charge of naming therapeutics, which is a committee called the WHO International Non-Proprietary Names, the IN program, they've decided that we need more sophistication than just calling everything a MAB. for all as yet unnamed antibodies. So this is only for new kids on the block, not anyone's there. And they're going to now have 4 different suffixes. So the TUG stem will be for monospecific full-length and FC unmodified immunoglobulins. The BART will be monospecific full-length immunoglobulins with engineered constant domains. The bispecific and multispecific immunoglobulins of all shapes will be the MIGs, and the monospecific fragments derived from the variable domains will be MENTs. So watch out for TUGs, BART, MIGs and MENTs. And the listeners don't know, but Hans has stepped out for a little while. He'll come back in a minute to say goodbye, but I reckon we quiz him on this next episode.
That's a great idea. So did they explain why they did that, Eva? They're just running out of words with MAB at the end, or?
No, because you can add MAB to everything. I think it shows the sophistication of the development and that you want the name to tell something more than just it's a monoclonal antibody. You want it to say how it's been derived, and these different 4 categories give you a lot of information just with a very short suffix. There you go.
Fabulous.
I like BART. I think they should have named them all after the Simpsons, shouldn't they?
Madge. What's her name?
Madge.
Homer, Madge.
We should
Melita.
join that committee. What a fun committee to be on. Melita from Yoga, it's a great pleasure to ask you about the paper that changed your practice. So tell us what the paper is and in what way it changed your practice. Some people do this segment as the paper that changed my life. So if it also changed your life, let us know.
Well, it might be changing my life. We're not sure yet. I'll let you know in a few years' time. So the paper that changed my practice is a paper that was published in 2019 by Diana Mandelka, is the first author, and it's called Germline-Focused Analysis of Tumor-Only Sequencing and Recommendations from the ESMO Precision Medicine Working Group.
So why did you pick this paper? What's so special about it? What impact did it have?
So I guess the premise of the paper is that with precision medicine and tumor testing, that is becoming, I guess, more commonplace now, and sort of more and more people taking that up. When we are testing tumor for genetic variations or mutations, if someone carries a germline or an inherited predisposition, an inherited mutation or pathogenic variant in a cancer predisposition gene, we will also see that on the tumor testing. And when it's just tumor that's been tested, it's really difficult to tell which is germline and which is somatic, which is tumor only and which is heritable. And heritable mutations have not only impact on the patient that we are here for, but also their wider family. And so this paper gives some framework in terms of how we might be able to, what are some clues that we can use to tell which of the people should go on to have germline testing.
Yeah, I'll challenge you. There's lots of papers like this. What's so special? How did it impact your practice?
Well, there actually aren't a lot. There are papers that will say that we've done tumor testing and paired normal sort of DNA testing, and this is what we found, and they're a small volume of patients, whereas this is the MSK impact testing, so it's a very large cohort. And to date, I haven't seen a paper that is as well presented with as clear guidelines in terms of sort of when we should be thinking about it.
Perfect. So you've actually advocated, I'm going to go and read that paper, and I hope the listeners will too. Thank you very much, Melita Zahid. It's been a pleasure speaking to you about yoga on our OJC Meets Yoga podcast and hearing the paper that changed yours and probably should change our practice. Thank you very much.
My pleasure.
So, 2022, are we like COVID? Have we peaked yet, or are we still going on and on? Find out in our next episode. Thank you very much, Professor Hans Prenen.
Thanks, Eva.
And thank you very much, Associate Professor Craig Underhill.
Thanks, Professor Segelov. Thanks, Rachel. Thanks to all our listeners.
Bye.
Bye.
Bye-bye.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.